Hello and welcome again to the AHF podcast live. Today on the Anterior Hip Foundation podcast, we're going to be joined by Francisco Gomez Torres, an orthopedic surgeon and innovator, and a passionate voice for Latin American orthopedics. And interestingly enough, there was an earthquake today not too long ago in Mexico, and that caused a little bit of our delay to the broadcast. So we're happy to know that Dr. Gomez Torres is safe and that he's going to be joining us here momentarily. Dr. Torres, from founding OsteoFit in Mexico City to shaping the next generation through mentorship and global collaboration, he's redefining what it means to lead with both skill and heart. Whether in the OR, behind a podcast mic, or climbing a mountain, he's on a mission to restore movement, inspire others, and elevate equity in surgery worldwide. Dr. Torres, welcome. I hope you're okay. Is everything okay in Mexico where you're at?
Hello, Joe. It's really nice to hear from you. I'm so sorry to be this late, but guess what? Welcome to Mexico City. There was just an earthquake and the whole hospital was downstairs. We are up here right now. It's so good to greet you again. Thank you again for the invitation. How are you?
I'm well. I'm just happy to hear that you are safe and well, and hopefully your patients and your staff and your family are safe as well. So thank you for joining me today.
Thanks to you, Joe. I would like to start just telling you, don't you miss these kind of experiences back in Switzerland?
It's been a while since
we
have
an
earthquake here. Yeah, no. But I really want to know.
You're missing it.
Yeah, I'm sure. I'm really interested in hearing. We had a chance to talk briefly at the AHF meeting in Nashville in June. And but I'm interested for you to kind of tell me about and share with our audience a little bit about what inspired you to pursue orthopedics, and specifically, how did you end up getting involved in hip surgery and in anterior hip surgery? We learned it's quite uncommon in Mexico.
Yeah, you're totally right. Well, I would like to start telling you that since I was a kid, I was really exposed to medicine because both of my parents are doctors. So my mother is a family doctor and my father was a surgeon. Since there, I do remember to be the whole time with them. I was raised with another two brothers who are not at all doctors. They see blood and they get dizzy. So I was the one. They were just muggles. So after I was exposed to this, I kind of like it. I studied medicine back in Mexico State. I even got this. I was like the president of my class. So I was always pursuing this kind of leading. And from there, when I was on my internship, I had the chance to have these rotations through general surgery, orthopedics, internal medicine, pediatrics, and stuff. And I saw that orthopedics was like the most, how you say it, decisive. You perform, somebody got broken, you perform a surgery, and it's healed a month later, which is something like, for example, internal medicine doesn't have to, you know how to treat diabetic. Maybe you can control their issues, but it will take years. Well, I mean, it's not even, there's not even a treatment right now, no? Maybe soon, but that was the way I chose orthopedics. And then I got a doctor who, on a vacation, he told me, you should come to me to the surgery room. We can see if you like it. And damn, I saw a hip surgery that day. I said, yes, this is the thing. So I studied for my um, specialty exam. I was the number 16 of the whole country. So I
Oh,
have
wow.
the chance to choose.
Yeah.
And after that, well, the rest is history. I studied in a IMSS, which is like the biggest public service in Mexico.
Okay.
And from there, after COVID, I started to create these kind of congresses for students and to join some leading voices about orthopedics. And a doctor, Dr. Victor Manuel Ilizalituri, was one of my guests. He
Hmm.
was delighted because of the effort, and I think that was the way he invited me to join his team as a fellow surgeon at the National Rehabilitation Institute here in Mexico, where I learned hip and knee reconstruction surgery with him. He is like a mentor to me, and I do appreciate the way he ta- uh, taught us on
Hmm.
that time. But as here is where the story starts. Some months ago, I was reading um, this book Dr. Mara signed for us at Nashville, and
The
I
anterior
saw
hip
that
book.
yeah, yeah,
Yeah.
I saw I saw he had a mentor of his who was performing surgeries in a posterior way or maybe a lateral approach. And when he decided that this wasn't the most natural way, uh, it was because he had the chance to hear from Letournelles. You know,
Hmm.
he writes on his book that the first time he saw him, it was because Dr. Letournelle was doing acetabular fractures through a anterior approach.
Hmm.
But then he decided to join him in Paris, where Dr. Letournelle was performing anterior approaches for hip prosthetics, and that he even had a table for it. So it was like, for me, maybe 30 years later, but it's the same history. Here in
Yeah.
Mexico, I don't know if it's a cultural matter, but the anterior approach is might be not the most acceptable approach for the leading surgeons today.
Yeah.
I even
In
told
Mexico
you, Doc. Yeah,
specifically.
yeah,
Yeah.
yeah.
And we'll
In
get
Mexico,
into a
in
little bit
Mexico.
about, I'm going to want to learn a little bit about why you think that is and how you think that might change, but we'll get to that.
Sure, sure. I'm your guest today, so I'm so happy to answer your questions. As well, I do have some questions for you
Yeah, of
because,
course.
well, I can see you as a mentor also. I think I do have a lot of to learn from you and the whole AHF crew.
Yeah. Well, I think the AHF itself is a community of learning. So we all learn from each other. And there's a lot that we can learn by having these sorts of conversations, both locally, nationally, and internationally.
Yeah. For example, I would like to know if the anterior approach was all the beginning for you, or if you have to make this switch between approaches when you first started.
Well, most of my residency training was in posterior approach and direct lateral approach. And I first saw anterior approach at a course when I was later in my residency years, and I thought it was very interesting. I got to meet Dr. Matta. He taught the course. And when I came back into practice after doing my fellowship in Switzerland, where I saw some anterior approach towards the end, I decided that I wanted to start my practice doing all anterior approach. So when I began my practice, I just started doing anterior approach right away from the get go. So My training was a little haphazard. It's different than it is nowadays, for sure. But we made it there. So that's how I ended up with anterior approach. But that leads me to a question. Was there, you talked about how you kind of found a mentor in hip and knee reconstruction surgery. Was there a particular case or patient or conversation that you had during that training that made you feel this is exactly where I'm supposed to be? This is what I'm supposed to be doing, and that confirmed the decision you had made?
For sure. I must say that, for example, in this practice I had as a fellow surgeon, it's always in the very same. Now you can't change the approach because you want to. You have to follow strict rules because this is the school we teach in this institute. Or, for example, as I told you before, I was couple of months ago, I was trying to. I was working in IMSS where they do have their own school. They do hips laterally mainly, and I heard from this colleague, a doctor who have learned the anterior way in the US. He was performing his cases under the water, as we say here, because he wasn't allowed to. Well, this doctor even got punished. They took his consultation and he was changed to another service. So I think the way I have been in touch with the anterior approach is mostly with colleagues of mine, friends which I do perform hip surgeries, but in our own, we have our own patients or private patients, and we gather a doctor from Central Mexico City, a doctor from Bolivia who now works here in Mexico City, and I myself, and we do perform the anterior hip surgery in our own way, as the way we learn. One of my
Yeah.
friends learned at the Hip Institute with Dr. Dom, for example, and this other friend of mine learned in Magdalena de las Salinas, which is a hospital here in Mexico City.
Mm-hmm.
And I did my own thing, learning through them and through you, for example, and like this, like water drops. I have been learning on my own. As you said before, I'm kind of an entrepreneur, but I'm looking for my practice everywhere. I even went to Switzerland at Basel, where I had the chance to perform with Dr. Karl Stoffel, which I do admire a lot. He taught me some tips. I went to the AO courses at Devos, at Luzern. So it's all kind of a mix. You have to look for your own way, and more than look for it, create it in
Yeah.
some way. Yeah.
Give me a little bit of an idea of what's the medical care system like in at least in Mexico City, and is it the same all throughout Mexico? Is there nationalized healthcare? Is it private? Is it a mixture of public and private? Tell our listeners a little bit about how healthcare is delivered in Mexico so we can understand the environment you're working in.
Sure. Here in Mexico, we have two different ways of doing things. The first one is the public one, which is divided mostly into three institutions, which are IMSS, ISTE, and Salubridad, which is health in general. These three services are the public ones. Yeah.
Okay.
So we are, how do you say? We do have, um, we are stuck to the money the government gave us to
Okay.
perform surgeries. So, for example, to do an anterior approach, you know better than me that maybe we do we need special instrumentation to place this uh, how do you say, prosthetics. So it's kind of hard for the government to pay, no? And through the public to the private one, well, we do have the insurances, which do mostly in the biggest hospitals like this, like Hospital Ángeles Pedregal. But there is also a way where people can pay on their own without having an insurance. So there are three kinds, you know, public,
Yeah. Yep.
private, or a hybrid one. Yeah.
Self-pay. Are there, so when
Self-pay.
we had Richard Field from the UK came and gave a talk at the Anterior Hip Foundation about anterior hip replacement in the UK, which is only about 1% of hip replacements, between 1 and 2%. Mexico is similar in its percentage, but he also described there's the public system, there's the private system, there's the self-pay, and then there's also the public system that, for lack of a better term, contracts out certain types of cases to that they are not able to handle within the public hospitals to private institutions who will take public patients. Does that also exist in Mexico, or is that aspect not similar?
Yeah, it does exist, but it's not like the biggest way of doing things. It's mostly because the hospitals are very crowded, so they
Yeah.
choose to deliver this kind of patients to a specific center, you know. But I have only heard of that maybe here in Mexico City and maybe in Monterrey and Guadalajara. So it's not like the most common thing, but
Okay.
I think things are going to that way because the public service it's full, it's overcrowded,
Yeah.
awfully. Yeah, we do
How
have
much
that
do
problem here.
Yeah, the overcrowding problem.
Yeah.
How much do patients in the public system in Mexico, how much do they have input into how they want their care to be delivered? So could somebody in the public system say, I want an anterior approach hip replacement, as uncommon as that might be in Mexico? Could somebody say that and expect that that's what they would get?
I must say the patient doesn't have an option when they are through the public service. It's
Yeah.
mostly the decision of the service, maybe the decision of their surgeons. But no, as far as I know, the patient doesn't have the right to choose, but they can talk with their doctor. And if he does know the anterior approach, maybe it's a possibility. Like in that hospital I told you before, the doctor that was doing his own anterior approaches, but he got he got punished. It's crazy.
Yeah. Well, and that leads me to my next question. If you could change one thing about how anterior approach hip surgery is either perceived or practiced, or it sounds like it's not taught much in Latin America, in Mexico, what would that be? What would be the first thing you would change?
Yeah, well, I think there is a cultural problem because of doctors that are not willing to change their approach. I think that's the biggest thing. The big names, the names that have been with us a lot of time, they are skeptical or they do not want to change this kind of technique, mostly because well they don't want to lose their power position, you know,
Mm-hmm.
as we saw in Nashville, as I have been watching through the days during my surgeries, the surgeries of my friends or colleagues, and we see this kind of better results. I do remember a doctor who told me in Nashville, the worst blind is the one that doesn't want to see, and that was Dr. Mara. So It's crazy how we are so renuent to say no, no, keep it lateral, keep it posteriorly because it's the better. I even had a discussion with a friend of mine. I mean, a friend of mine told me the posterior way is the way, and I was saying like, dude, you are like a shoulder surgeon. Why are you talking about hip surgery? That that's the way. It's like discussing about the football. Football is something big here in Mexico, and people
Yeah.
gets it breaks relationships. It was the same with this guy. He was
Well,
saying, "Why are yeah?" Go on.
I,
I'm sorry.
I know that's okay. I was going to say maybe it'll take a famous footballer from Mexico to get an anterior approach hip replacement someday to change the
Now you're
mindset.
talking. Yeah, yeah, yeah. I do remember having a football coach. He was already retired, but he was a very famous football player back in the day. He had an anterior approach, and he's doing great.
Yeah.
He's still playing football. He tells me that when he's playing football nowadays, he plays, but when the other teammate comes too closer, he just drops the ball.
Yeah.
But he's playing football. It's crazy. He
Yeah.
shoots and he scores from far away. He has it still, but it's crazy. And people doesn't maybe they don't know that yet. I think
Maybe they
another
don't
thing
know
I
that.
will
Yeah, that
change.
he's had a hip replacement.
Yeah,
Yeah.
yeah. Maybe
Yeah.
the thing I will try to change will be making this info even more available for people that wants to get better results. I'm not talking about patients because patients do come and they ask for the AMIS approach, but I
Uh-huh.
mean through another colleagues, through
Mm.
doctors, through another hip surgeons that are stuck because they learn that way as the way I learned back 4 years ago when I was doing orthopedic surgery, but not following hip replacement.
So, talk to me a little bit more about the group of orthopedic leaders within the Mexican community who have um, maybe some oversight over what they perceive to be quality and what they perceive to be the right way to do things. Is this a formal structure within the Mexican orthopedic community, or is it a bit more informal and is this the elder statesmen, so to speak, or stateswomen of the orthopedic community who are telling you, quote unquote, the right way to do things?
Yeah, well, I think mostly of them, it's not like a formal group. It's this bunch of groups that have been through a lot of time. For example, they do work a lot with the insurance companies. They have been there forever, and they keep growing because they do accept more fellows, more doctors to join their team, as they are the voices that resonate between us. Um, they are the ones that have to change, I guess. I mean,
Yeah.
it's not very easy for me to raise the voice and to make people hear me, but little by little, as what a lady was telling me yesterday, we had an interview with a social activist who told us, don't you ever give up. Just if you can change a person a day, it's okay. I think we have to keep pushing with this kind of efforts. I don't know, Joe, if you will have the metrics of this speak later, but I would like to know if Latin America is listening, because we did have a lot of talks with our friends back in Brazil, Chile. I even had a discussion with a research team in Egypt uh, who was committed to hear this talk.
Mm.
I think we have to keep pushing to make people's mind change, especially these big guys that have been there forever and that are negative about the anterior hip,
Yeah.
but just because they have it, they don't know it. Maybe they don't want to change. I mean, 20 years doing the same procedure the very same way. I do understand that they might be in a comfort zone. But for example, Dr. Sa also talks about his transition through the from posterior to anterior, which is something crazy for me.
Mm-hmm.
I it's kind of remarkable for me because it's a 180 degrees change. It's totally
Yeah.
different, but I can say Dr. Shah is having great results, and he even talks about it in his book also.
Yep.
So
Yep. And just to address one of your comments there, we've got live about 15 people watching us right now, which is for a first live podcast episode. I'll take it. And I want to remind those users on YouTube and on LinkedIn that in the latter
perfect.
half of this discussion, if you have questions for Dr. Gomez Torres or for myself, we've got our producer Lila behind the scenes, and she is feeding us the best comments and questions that you leave. So please feel free to be a part of the conversation. We would love to have you. And I wanted to sort of follow up because one of the things that you seem to have done or seem to have put together in your quest to bring anterior approach to Mexico and to Latin America is you have really made a lot of international connections or made international global outreach something something that's part of how you learn, but also how you connect. How do you stay engaged with the orthopedic community internationally? How do you cross borders like that?
Well, I would like to say that since I was a kid, I was like a really friendly guy. I don't know why is it easy for me to talk to people and to know if we can be friends or no. It's okay if we don't agree in everything, but I do like this kind of communication. I don't want to be flat with the people. I want to know a little bit of them, and if they want to know from me, it's okay. So I think it's the way I do friendships with people that took me. Well, I took it international. I say I am making friends all around Mexico. Let's try in Switzerland. Let's see if I can make some friends there. I did make some friends, and they were for lucky me, they were AO officers. So then I got engaged with the AO Foundation, and I do love that. I am working nowadays with them also. For example, when I went to Nashville, I did find this group of very enthusiast colleagues, which are the Burkle Fellows. I can
Mm-hmm.
tell you that everybody has a special talent, especially, for example, Dr. Ahmed Omar from Egypt. He, as soon as I got in touch with him, we had a click, and I was invited to participate in his research group, which is an author of more than 50 research, for example, no,
Wow.
and he is encouraging his students to do as he to publish and publish and publish. So I can see that that's the true benefit of having friendships that matters. It's not just being friends; it's trying to work together. In back in Nashville, for example, I was looking for maybe any chance to get a traveling fellowship info. That was another thing I was looking for. It's not just talking for talking; it's with a purpose. No,
Mm-hmm.
to get in touch with people, maybe searching for the exchange of benefits. If I can do that, the Anterior Hip Foundation put some attention of them in Latin America, I think that's something invaluable for the whole region. If some doctors, some teachers of mine are listening to this, and they see that maybe podcasts are nowadays the way television evolved, for example, or the broadcasting. Um, it's a new wave, well, a new way of communication, and I think it's as the anterior approach is the future of communicate. If not, I wouldn't be able to talk to you from Switzerland to Mexico with Laila or California. It's crazy,
It's
but I do
crazy.
love it. That's the way I am doing podcasting right now. The last year was amazing to get in touch with a lot of people, friends from New York, friends from Belgium, some doctors from Asia. For example, I was invited to give a talk next February on the APOA, the Asia Pacific Orthopedic Association. So maybe I will be there for next February.
Mm-hmm. Mm-hmm.
It's the way things are happening. I'm not just sitting and with arms crossed. I'm looking forward to connect with people, as you say, but that's the way things are happening. I'm
You clearly have an interest in technology, and you have an interest in using that technology to not only to learn but also to teach and to engage. I'm curious about your use of technology in the operating room. And I just want to start with a basic question about your setup. Do you have a technology enabled OR setup? Is it pretty basic? Is it more advanced? Can you walk me through what features kind of matter most to you in terms of your OR setup?
yeah. Well, first of all, I would like to say that I did learn to perform hip and knee surgeries in the traditional way to begin with. At the very first, I wasn't able to manage the robotic arm, but nowadays we do have access through this kind of technology, especially in the private sector. About the public sector, it's a little bit hard because of the economics. But
Yeah.
now that we do have this kind of liberty of freedom to choose, well, we do perform with a robotic surgery in a site. We do have a tech guy who is taking care of it. Um, when we are performing some um, surgeries, we do have this kind of how do you say like the belly system,
Mm-hmm.
to
Yep.
match the pre and the post op, even with a pre trans uh, visualization of if we are okay.
Yep.
So I can say it's not like the most equipped um, OR, but it's not also like the most basic one. I think we do defend ourselves. I think there are doctors who are more in a need of having everything, but
Mm.
I'm kind of I don't want to get so used to this kind of technology that then I kind of forget how to make them traditionally, because, well, another thing I would like to say is that apart from Mexico City, I do perform surgeries across the country. So I
Uh-huh.
try to go, I don't know, maybe California, sometimes Morelos, maybe South Mexico. We do try to help in different ways to the people. Sometimes I perform surgeries with another surgeons who ask for my help. We're kind of um, a Mexican, how do you say? We try to communicate to make things possible, but
Sure.
that's the
You
way. I don't have a
collaborate
robot
within
always.
the.
Yeah,
Okay.
yeah,
Interesting.
I do
Um,
collaborate a lot.
do you find difference in access to implants, different quality of implants depending on the place that you're operating at, whether it's public or private, or do you pretty much have the same type of implants available wherever you are?
Unfortunate, I don't know if that's unfortunate, but no, I do have like a, a whole options of implants. Uh, I do. I would like to say that I do have my favorites. I
Yeah.
do perform mostly with three kind of implants. But if I'm back in Mexico State and they got these prosthetics because of the budget, let's make it. You know.
Yeah.
So I think that we do have to be also very versatile with these kind of matters. If you get used to a single thing, it can be you can get into a trouble later, um, and maybe it's the time for me. Maybe later when I uh, you know base totally my practice into a single thing, then I will start doing with only one implant,
Mm.
one kind of implant. But nowadays, I'm trying from everything.
We have a question from one of our users on LinkedIn about specifically about implants, but about custom 3D titanium implants, wanting to know if you have any experience with those implants, and if so, if you've encountered any challenges with them.
Well, we do have a friend of us who is mostly into this. With this technology, the thing that we have found is that after you have the cuts, which have to be really specific through a TC, a CT, for example, um, even when you perform very good the surgery, you can't expect everything because as it is a 3D personalized system, you depend a lot in the activities this person is doing. We don't have the record of how this implant is going to work because it might be is so personalized that you can't have like repro- reproducibility of how you say cases before. No, so every case is different. We even have one day this person that the implant just came off
Mm.
from the iliac bone, and we have to re-enter and to fix it with more material. But that was an experience we don't want to have again. And we have had more, a little bit more of experience with the trabecular implants that, these I did forget the name, but we do have more practice with augments. With augments,
Uh-huh.
it's
Okay.
mostly more than 3D printed. Besides that, it is expensive as well, the
Yeah.
3D printing thing. Yeah.
We do have one user who commented on LinkedIn, and I'll just read the comment that I have here. It says, "I believe that the reality of the Mexican healthcare system is so similar to the rest of Latin America and so different from the American healthcare system, where decisions often depend not on what the patient wants or what the surgeon prefers, but on what is available at the time of surgery in each case." Is that your experience?
Well, I have to say, Joe, that I have heard that a lot of times. What about you? Do you find it like something crazy? Because yeah, it's a reality in the public service here in Mexico. Yeah, but I don't know that maybe in Colombia is very different.
Yeah.
Colombia is kind of more private thing.
My only experience operating in Latin America was in Nicaragua, where we had an opportunity to go as an educational exchange when we were residents. And what I recall from the uh, cases that we did in Nicaragua, at least at the place where we did them, the patients had to buy the implants basically out of pocket, and so it was you put in whatever they could afford. And if they couldn't afford, you took whatever you had that was, on the shelf if there was something available, or that could be donated by a company. But it was an exceptionally different situation than what I've experienced in the U.S. healthcare system, and certainly different than in the Swiss healthcare system. But it also sounds like that's a bit different. Yeah, a bit different than what you experience in Mexico City.
Yes, yes, I can say that. Well, here as the population is growing like never before, the population is still growing as fast as 30 years ago, maybe a little bit more. Um, the institutions, they get stuck into trouble. We even had like 15 years ago, the how do you say, the pensions, the jubilations,
Yeah,
yeah, they
pensions.
were took off the federal budget because it wasn't possible, affordable for the government to keep those payments. So nowadays, we don't have jubilations anymore. It's something crazy. You will have to work until you are incapable of. But
Right.
it's mostly because we don't have the budget already. So imagine if that's the way things are happening. You can expect anything from a public service to give you on prosthetics. Yeah,
Yeah. We have some great questions coming in. I want to read this one from Angel
that's
Alarcon, who's an
great.
orthopedic surgeon. What common mistakes do you see surgeons make early on in their anterior journey, and how can they avoid them? What have you seen?
Well, I would like to tell you, even I do feel like I am a young surgeon on this. I'm not the most experimented, but I am on my curve already.
Mm,
I think one of the biggest mistakes was not not to locate the right intermuscular segment.
mm,
Sometimes I was a little bit anteriorly, a little bit more, or in the later cases, I was getting a little bit posterior. So nowadays, I do have like this kind of metric, not only with hands but also with the feeling,
mm-hmm.
and I do. Um, Now I can initiate my approach just right in the way, in the place I wanted to. Yeah, to make a little flip of the fascia. That's the
Mm-hmm.
way to be.
Okay.
I don't know you if you have any trouble, because I think the approach is the 60% of the surgery. The implants, when they are well located. To expose the femur is another thing I would like to discuss, but I think mostly it's the approach. You have to be real secure in the approach, and then the surgery will just flow as you want it to.
I would say the biggest mistake that I see early learners make in anterior approach is some of them don't understand how many people have come before them and have made the exact same mistakes they've made. And they feel like, with as successful as anterior approach is, that if they talk about anything they're having trouble with, or that they're, a mistake that they've made or a difficulty that they've encountered, that they would somehow be looked down on. When what I have found, at least with the Anterior Hip Foundation, is a community of people who have made every single mistake that you can make with an anterior approach and would love to talk to anybody who is struggling, so that they can help them through it. And it's the idea that you need to hide things that are difficult for you until you just get enough cases under your belt and they get better. There are people who are out there who can help you. And you're an example of how you do this. You reach out and you cross boundaries, you cross borders, you cross cultures, and you try and find answers to the problems that you're encountering and the questions that you have. Another question came in. What specifically do you think needs to happen for anterior approach hips to become more common and even widespread across all of Mexico?
What would be? I do think that, you know, an actualization in education, it's a must, because if you enter a fellow, okay, you enter into a hip reconstructive fellow, okay, but the teachers are doing lateral approach,
Mm-hmm.
and then the fellow asks, can we do maybe one anteriorly, but the practitioner doesn't even know it, or maybe they have here only bad reviews about the anterior approach, and they are not trying to excel this myth. No, I hear that it was like a crazy approach. Oh no, it's not any better than the lateral or the posterior, just because they heard from somebody that heard.
Yeah.
So I think that's the very most important issue, is to make an actualization, or to improve, um, to make it, put it on the table as an option, not
The
saying just
education,
no.
specifically the
Yeah,
education. So
yeah.
how it does, and I'm going to ask a little more detail about this because one, I think
One thing.
yeah,
Yeah, yeah. I got you. Just to add a little bit, maybe, for example, I am. Unfortunately, I don't have a program to teach now, or maybe the friends of mine who are working as freelancers or their own bosses, we don't have like this program, a specific program of fellows, but we are avid to learn the anterior way. Well, I think this has to be into a program. There are no programs where the anterior approach is taught. I think that's the most important thing.
yeah.
The time one teacher starts performing anterior, people will go there and try to learn, as I did in Nashville, as we are all doing.
Well, and I remember early on. So nowadays, in the U.S. and certainly both in the U.S. and in Europe, it's quite common for any of the fellowships that you go to learn hip surgery. You're going to learn anterior approach. That's very common at many fellowships. But when I was learning, there were not as many fellowships that were offering that as a regular opportunity. And the education was mostly coming from partnership with industry. Is that something that you can do in Mexico before the teachers, so to speak, take it on? Can industry be a help in that?
Of course, I think that every time I do approach with a rep, and they start talking me about their new hip system, it's okay. Oh, it's really great. It has trabecular metal. It has hydroxyapatite. It has vitaminide. How you say, polyethylene? And I
Yeah.
said, is it possible to make it anteriorly, or do you have any special instruments to make it anteriorly? And they say no, or they say yes.
Yeah.
So I think that's the way I think the reps can get into this, to making the tools perfect for their implants, or to make them anteriorly. I do now have, for example, I was talking with nowadays with a new rep I haven't here before, and they are bringing a Korean, I think it is, hip prosthetics that has its own instrumental to do it anteriorly. It's the first
Wow.
one I have here heard that is not American, for example. So, or like the Bedacta. I don't know if we are able to talk
We at the
about.
Anterior Hip Foundation, we are free to use product names, and in fact, we encourage it.
That's great. That's great
Otherwise,
because with
how's anyone going to know what you're using if you say, I use this, and then they find something that looks like that, but maybe, use the name. It makes sense. But
Yeah, yeah. For example,
I was going to
Sorry.
say we received a comment as you were speaking from David Cantu Morales, who says exactly the point that you were making. We need more surgeons performing this approach so that the implant companies start requesting the necessary implants and tools. Even if they requested them today, the Mexican FDA, which he says COFEPRIS, if
Yeah.
I'm pronouncing that correctly, takes between 3 to 5 years to approve them. So just to give an example, trabecular metal only became available in Mexico about 5 or 6 years ago. So if we want to have, for instance, the Actus stem, collared implants, it'll likely take another 3 to 5 years before they arrive. So that sounds like exactly the point you were making. There needs to be this relationship with industry to get the technology in and the implants in to facilitate the approach. So working with industry seems to make a ton of sense.
Yeah, I do remember. We had a talk a couple of weeks before on a Saturday, a
Mm-hmm.
Sunday. I was talking to you that a Johnson and Johnson rep came to me to say, "Hey, you had a great time at Palm Beach, right? We met you there." Yeah, and he was talking. We were talking about the. I invite him to the office, and he showed me the implants he had and stuff. And as I was talking with him, because well, I attend to a Palm Beach in an AO course where
Mm-hmm.
we had some kind of tech, some
Mm-hmm.
kind of hip replacements, some kind of knee replacements, which were very similar but different to the ones we used in Nashville. For example, in Nashville, we used the king size. He was asking me, is the number one or number two? And then we research. But for example, and I asked him, why don't we have king size in Mexico? And
Yeah.
he said, like, oh, doctor, first than Mexico, you should seek for Chile or Brazil, where the FDA from those countries is not as bureaucratic as the Mexican one is. So
Yeah.
he, if that was his first comment, is because it's a very hard thing to introduce these implants into a country. So
Yeah.
he said, you are like 10 years behind. Chile might be 5, Brazil maybe 3, and then it's Mexico. So
Wow.
you should start looking what's happening in Colombia or Chile to see what's coming to Mexico. It's like, really? Do they have king size there? No. So king size is coming maybe in 20. I don't know. But
So it's
that's like
yeah.
some kind of.
It's kind of like you have a little bit of time machine. You get to see into the future a little bit. It's just it's unfortunately the present for others, but um, so I know I do. We've been talking for almost 50 minutes now, which is great. And but I want to see.
Crazy.
I know you had mentioned you had some questions for me, and so I wanted to be respectful of your time, and I'm happy to answer any questions that you might have.
Thanks a lot, Joe. I mean, I don't want to extend this that much, but I would really like to ask you, as a leader you are, because well, people that follows the AHF already know that you are, well, now you are the ex-president of past president from the AHF, but
Right.
I would like to know, how was your how would you say, mandate? How did you feel with your mandate for an institution, well, a foundation that it's kind of young, as we might say, with these 8 years nowadays is having the EHF,
Yeah.
and if you have some issues through it, or how was it possible that you got to be a
Yeah.
president?
Yeah. Well, so the question about the mandate and the organization itself and its youth and inexperience in an organization comes with some benefits and some drawbacks. And the benefits are great. You don't know what you don't know, and so you oftentimes take on things that Maybe somebody who's a little more experienced or a little wiser would say, I wouldn't do that, but you do it, and it ends up, sometimes being a big success. We have always focused, our main thrust for the AHF has always been the annual meeting, which every year continues to grow and grow in popularity, in size, in offerings. And that's, my mandate for this year was to continue that trajectory. And the one thing I'll say that all of us in the leadership team of the AHF, and we have so many fantastic people, helping us. And I mean, I can embarrass them all by name, but they know who they are, who do amazing things to put that meeting on. But the goal of continuing that meeting, growing it, and trying something a little bit new or a little bit different every year. This is the first, I would say, within the last 2 years, is the first time that the entire leadership team has felt like whether we do anything or not, the AHF will continue. Like it's not a mature organization, but it's gotten to the point of maturity where it's a train that's moving along the track, and it would take some effort to stop it at this point. So we all feel very comfortable with where we're moving as an organization. I am exceptionally proud of the fact that we get to hand over the reins to Dr. Charles Lowry, who is my vice president. He's an incredibly skilled, gifted surgeon. He's an incredible person. He's an incredible visionary. And I couldn't think of a better person to hand the organization off to. And next year is only going to get better. And I don't know how, and I don't know why, and I don't know, I don't know when, but it's going to just keep getting better and better. So it's been one of my professional highlights of my career, is to be honored to work with the people at the Anterior Hip Foundation.
That's so great to hear. The next question will be, what do you see for the future of the AHF? Where is it pointing? Because we did have like this European meeting last month. So I would like to know, how do you will you see the AHF maybe in the next 5 years, or any point you would like to, figure out?
Well, the good news about being the immediate past president is I get to say all sorts of wild and crazy things that we could do in the next 5 years. And I get to rely on a whole other group of people to make it happen. But,
it's not pressure, but
there's no pressure. Yeah. I mean, we have a vision to kind of take a page from you and expand our outlook internationally. And whether that's through direct collaborations or support of other organizations, or whether it's through, directly creating organizations in different regional areas. We haven't quite figured that out yet, but, there were a number of us from the leadership team at the AHF who were at the European Anterior Hip meeting and participated as the faculty. It was a great experience talking with the European surgeons. It was a great, it felt very much like the same sort of collegial family environment that we put on for the AHF. Nice. I know there's interest in doing this in Latin America, in South America. There's been tremendous interest from the Oceania region in Australia and New Zealand. And
nice. Crazy. The Australians are, for example, a big team, right? Yeah. The Anterior approach is happening a lot in Australia, as I can see.
They're almost 40% anterior approach. Yeah. And you know what? I know I'm answering questions, but I just got one that came in on LinkedIn that I'm curious to hear your thoughts on. Do you have experience doing anterior approach through a bikini incision? And that's the first part of the question. And the second part is, can you give, from your perspective, an outlook on computer-assisted or computer-navigated hip replacement surgery in Mexico and Latin America. So bikini incision and computer assisted, computer navigated.
Well, I can tell you that about talking about the bikini incision. I even got an earlier discussion through LinkedIn with you where we were discussing should it be like horizontal, vertical, angulated with a, a glimp. So I would like to pick these these words you told me that is not what the incision is creating, is that you have to understand that there has been plenty of patients, a lot, millions if not, that are having better results in any kind of incision. It's not the incision for
Right.
start.
Right.
Now, if you're asking about the issues one or the other have, we can say that the vertical incision it break more Langerhans lines, so there you can expect a little bit more of healing tissue issues. But doing it through a bikini incision, it might be you might attend to that question, but the bikini incision is not exempt of having cutaneous problems also, but
Right.
it might be a little bit more aesthetic because you are close to the part where the skin folds, but I mean, it's not the most important part of the surgery. And to close that question, I would like to say that you have to be comfortable with the work you are having. You have to think in what's happening inside
Yeah.
or even deeper, and the bikini is just the signature,
Yeah.
that you
Yeah.
will keep performing better day by
Yeah.
day.
You have to know
No?
what you're doing under the skin to make
Yeah,
the quality of the incision be the deciding factor about what you're
yeah,
doing or not. Yeah, I agree. And how about
yeah,
computer
and
navigation?
well, yeah, well, I do. I haven't been able to perform a robotic assisted surgery with a direct anterior approach, but I do have some colleagues that are doing it right now with the Mako system. I can even tell you that a month ago, the first ROSA hip surgery was performed at the very next door of a surgery I was having. So, and it was another colleague of mine who I do anterior approaches with him sometimes, but
Yeah.
I do know the patient is going excellent through with that system and with that direct anterior approach. It is possible. About doing navigation
Yeah.
surgeries, I haven't done them. I think I don't know. Well, my generation is not looking forward a lot into navigating, but we do are we are having the whole attention to the robotics issue. Maybe I even have in between my eyes the case of Dr. Sa and the T-Mini use he
The
is
T-Mini. Mm-hmm.
developing to, instead of having like this whole robotic arm, you just have your machine gun in the
Yeah.
hands and perform the surgery.
I'm curious. Do you think it's more likely that an implant company or that a company like a Johnson and Johnson or Zimmer Biomet would be more likely to bring down a robot to Mexico than they would a new set of implants? Just because of the size and impact that might have. Because I'm curious to hear
I
that you
think
have ROSA, but you don't have Concise, and you just got trabecular metal 5 years ago. That's interesting, right?
yeah, that's the way the cookie crumble, as somebody said. But I think I would like to take your words again, doctor, because as I told you before, you are like a mentor in a certain remote way. I think the most important thing must be to have a centered approach, centered patient approach. It's not about the tech, it's not about the market, it's not about the new robot, the new hip, the new implant. It's if the patient is having better results, we should do it. If it's just because there is a new robot on the market, that's not the objective or the reason why the robots should come here or the new set of implants. If we have the evidence that is working, okay, there is a reason to. But
Yeah.
if you are having the robot and your results are being just even uglier than the traditional approach, well, maybe it's not what you have to be looking for, right? So
Yeah. Interesting. Well,
yeah.
Dr. Gomez Torres, I want to thank you for really actually being kind of our test subject, right, on doing a live AHF podcast and engaging with a live audience. We've had pretty steadily about 15 to 20 people watching us. We've had, I think, some excellent comments and questions from our users, and I just want to encourage you, everything you've been doing to engage with the international orthopedic community. I want to say you're an inspiration to other surgeons, and I would encourage you to keep doing what you're doing. Keep fighting the good fight.
Thanks a lot, Joe. It's such an honor to be part of your guests now. I can't say that maybe having a podcast and do these international meetings, to get some friends and stuff, will take me to this place now. Now I wouldn't imagine that. So I'm really thankful with you, with Laila, with all the whole AHF for the Berkeley Fellowship, everything, because these things happen just because you are not seated waiting for the day to pass. You have to keep pushing forward. So I do would like to say once again, thank you for hearing, and thank you
Yeah.
for having a feedback for me and, well, Latin America. I hope they hear your words.
I hope they hear your words, and I'm going to take a moment to bring Lila on, just to thank
Great.
her for doing this in the background. Lila, thank you for being on the podcast. Oh, have you muted yourself? Excellent.
Can you hear me now?
Now we can hear you.
Oh,
That's
yeah.
perfect.
Hi, Laila.
It was such a pleasure working together and, looking for different topics to discuss today. You were very committed, Dr. Gomez Torres, so I really appreciate it. So for all our listeners, it took a little bit of work and effort from all of us to put it together. So I just hope you enjoyed it.
And we
even
hope to
the
get
earthquake.
a chance to do it again. Yeah,
Even
through an earthquake. Oh my gosh! I hope everybody's okay.
Very
All right.
eventful.
Thank you.
It was the
both.
announcement that the AHF was happening right now.
That's created the earthquake. Well, thank you, Dr. Gomez Torres. Thank you, Lila.
Thank you.
We'll do this here. And I just want to say thank you, all of you, for joining us for this live episode of the AHF podcast. And if you can, please take a moment to like and subscribe. You'd be helping us find more people just like you to share this type of content with. And if you have any ideas for a future episode or topics you want to see us discuss from any portion of the world, drop it in the comments below. You can find our normal episodes of the AHF podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube /at Anterior Hip Foundation, all one word. New episodes of the AHF podcast come out on most Fridays. I'm your host, Joe Schwab, asking you to help keep the hips in Latin America and wherever you are happy and healthy.